Finals SAQ29 Laparoscopy. The case: a 45-year-old man is scheduled for a laparoscopic Nissen fundoplication under GA. He is graded ASA 1. A. Describe how laparoscopy can cause adverse effects in this patient. Adverse effects may be mediated by trocars, steep head-up position, and pneumoperitoneum. Trocars may cause unintended visceral or vascular injury. There is risk of intravascular carbon dioxide embolus, and extraperitoneal gas insufflation may result in subcutaneous emphysema, pneumomediastinum, pneumopericardium, or pneumothorax. Steep head-up position may cause accidental extubation, venous pooling resulting in reduced venous return, reduced cardiac output and hypotension, and myocardial ischemia. There may be reduced cerebral perfusion pressure. Pressure injury may occur, and risk of injury from slipping may occur. Pneumoperitoneum. Respiratory effects include reduced FRC, atelectasis, VQ mismatch and reduced compliance. Carbon dioxide absorption leads to increased PaCO2 and respi acidosis. There is risk of barotrauma due to elevated airway pressures used to maintain tidal volume and EtCO2 against increased intraperitoneal pressure. Cardiac effects. On inflation, initial autotransfusion from splanchnic vessels occur. Then compression of IVC reduces venous return in the face of increased intrathoracic pressure. This leads to reduced stroke volume and reflex tachycardia. Compression of aorta and release of neurohumoral factors, such as that from renin-angiotensin-aldosterone system and catecholamines, cause increased SVR, heart rate, and MAP, maintaining cardiac output overall. There is increased risk of arrhythmias due to increased sympathetic tone. There is increased myocardial workload, risking ischemia in susceptible individuals. Neurological effects. Increased PaCO2 causes cerebral vasodilation and risk of raised ICP. If cardiac output reduction is significant, this may compromise cerebral perfusion pressure. Stretching of peritoneum may cause vagal stimulation, leading to bradycardia and occasionally asystole. Treat with vagolytics. Gastrointestinal. The patient is already at risk of reflux, evidenced by the need for this surgery. There is further increased risk of reflux due to raised intra-abdominal pressure. Pneumoperitoneum may compromise splanchnic blood flow. Hematological effects include venous stasis and risk of deep vein thrombosis. Renal effects. Increased intra-abdominal pressure causes increased renal vascular resistance, with increased renal venous pressure, causing reduced GFR and urine output. There is risk of AKI in susceptible individuals or with prolonged surgery. Liver. Pneumoperitoneum reduces liver perfusion. For further details, kindly refer to the YouTube video Physiology SAQ12 Effects of Laparoscopy. B. How may these effects be minimized? Patient selection. Ensure that the patient has sufficient cardiac and respiratory reserve to cope with the process. Risks are increased with ischemic heart disease, valvular heart disease, raised ICP, and hypovolemia. Good surgical technique minimizes risk of trocar damage and limits duration and pressure of pneumoperitoneum. Airway. Check ETT position after movement and inflation of abdomen. Breathing. Intubate the patient and provide positive pressure ventilation. GA with endotracheal intubation, muscle relaxation, and controlled ventilation is considered the safest technique as it protects against pulmonary aspiration and enables control of PaCO2 and PaO2. Systemic absorption of CO2 and raised intra-abdominal pressure will require increased minute volume and results in increased intrathoracic pressure. Aim for normocapnia, but beware of adverse effects of high intrathoracic pressure. Normocapnia can be difficult to achieve and may occasionally necessitate intermittent release of intraperitoneal gas or tolerance of a degree of hypercapnia. Use PEEP if high inspiratory pressures are encountered exclude endobronchial intubation and inadequate neuromuscular blockade, consider a change to pressure-controlled ventilation and reduce IE ratio such as 1:1. Cardiovascular system. Ensure adequate circulating volume, management of hypotension with inotropic rather than vasopressor drugs. Ensure that airway pressures do not further compromise cardiac output. Consider intra-arterial blood pressure monitoring and cardiac output monitoring for long procedures or in patients with cardiac comorbidities. Avoid excessive intraperitoneal pressure and limit duration. Neurology. Adequate filling and blood pressure is essential. Adequate neuromuscular blockade is required in laparoscopy to optimize operating conditions and limit intra-abdominal pressure. Muscle relaxation is essential, while docked in robotic surgery to avoid unexpected patient movement and injury. All patients must be considered at risk of conversion to an open procedure, and a plan for analgesia considered. Pain may be intense intraoperatively, but post-op pain is generally much less than for open procedures. Perioperative IV lidocaine infusion may reduce post-op pain and bowel dysfunction following laparoscopic surgery. At the end of the procedure, encourage the surgeon to expel as much intraperitoneal gas as possible to reduce post-op pain. LA infiltration of port sites and intraperitoneal administration of LA may reduce post-op analgesia requirements. Significant pain extending beyond the first day raises the possibility of intra-abdominal complications. Gastrointestinal system. Minimize face mask ventilation pre-intubation to reduce gastric distension and obscuration of surgical field, thus reducing the risk of stomach injury. Deflate the stomach with oral or nasogastric tube if this has occurred. Intubation reduces risk of reflux and aspiration. Rapid sequence or modified rapid sequence induction may be indicated for pre-existing reflux. Laparoscopic surgery is associated with high incidence of nausea and vomiting. Administer prophylactic antiemetics and prescribe post-op. Hematology. Thromboembolic deterrent stockings to reduce risk of DVT. Pneumatic compression devices are another option. Post-operative low molecular weight heparin should be considered. Joints. Adequate padding to prevent pressure injury. Ensure secure positioning on the table. Kidneys. Adequate filling and blood pressure to prevent renal or liver hypoperfusion. Metabolic. Devices that warm and humidify CO2 for laparoscopic abdominal procedures are in use, but their effects on clinical outcomes is unclear. Additional information. Examiner's report. The effect of steep head-up position and not Trendelenburg tilt was not appreciated by a number of candidates. A significant number of answers incorrectly referred to the effects of a Trendelenburg position raising intracranial and intraocular pressure. The question was otherwise answered with a good systematic approach to the physiological effects of a pneumoperitoneum and the adverse effects of performing a laparoscopy. If the exam mentions the type of operation a patient is having, it is for a reason. For example, cancer surgery, minimal opportunity for delaying for optimization, consider impact of radio and chemotherapy. Pelvic or lower abdominal laparoscopic surgery, often Trendelenburg position with its attendant issues. Ear surgery, consider nausea and vomiting. Day case surgery, think about optimizing analgesia and antiemesis in order to get the patient out within 24 hours. This table summarizes the physiological effects of pneumoperitoneum. What are the benefits of laparoscopy over laparotomy? This includes reduced tissue trauma, wound size and post-op pain, improved post-op respi function, reduced post-op ileus, earlier mobilization and shorter hospital stay, and improved cosmetic results. What are the causes of hypoxia during laparoscopy? Hypoxia may be caused by hypoventilation due to pneumoperitoneum and head-down positioning, reduced cardiac output due to IVC compression, arrhythmias, hemorrhage, myocardial depression, venous gas embolism, and extraperitoneal gas. Hypoxia may be caused by VQ mismatch, due to reduced FRC, atelectasis, endobronchial intubation, venous gas embolism, pulmonary aspiration, and rarely pneumothorax. Other causes of hypoxia in theatre are included here. Supraglottic airway device for laparoscopy. SGAs may be used for some laparoscopic procedures. However, this should be avoided if the patient has a history of reflux or obesity and the procedure is anticipated to be difficult or prolonged, especially in head-down position. A systematic review and meta-analysis by Park SK et al. In 2016 concluded that the incidence of laryngospasm, cough at removal, dysphagia or dysphonia, sore throat, and hoarseness were higher in the ETT group rather in the SGA group. However, the groups showed no differences in the rate of insertion success on the first attempt, insertion time, OLP, and other complications. Regional anesthesia for laparoscopy. Regional anesthesia is not generally used as the sole anesthetic technique because of the high level of block required to cover the pneumoperitoneum. An article by Bajwa S.J. in 2016 commented that various reports in the literature suggest the safety of use of spinal, epidural, and CSE in laparoscopic procedures. Advantages of regional anesthesia includes prevention of airway manipulation, an awake and spontaneously breathing patient intra-op, minimal nausea and vomiting, effective post-op analgesia, and early ambulation and recovery. However, regional anesthesia may be associated with few side effects such as the requirement for a high sensory level, more severe hypotension, shoulder discomfort due to diaphragmatic irritation, and respiratory embarrassment caused by pneumoperitoneum. Further studies may be required to establish the advantage of regional over general anesthesia for its eventual global use in different patient populations.